Welcome to our monthly Health and Wellness Thursday. Today is a talk by our lovely Dr. Hyo Park on embracing sexual health and pleasure after a breast cancer diagnosis. I'm Rebecca Crane-Okada, clinical nurse specialist and program manager for the Margie Petersen Breast Center. And I'm joined by our co-host, Alston Novak, who is an administrative support assistant with our teams, who will be monitoring the chat for any questions that you type in and also doing the recording. I want to welcome Dr. Hyo Park, who is a gynecologic oncologist and complex pelvic surgeon here with the Women's Health and Wellness Institute, who is actually seeing her patients in the Margie Petersen Breast Center at St. John's. And I will let you begin the talk on embracing sexual health and pleasure after a breast cancer diagnosis. Welcome, Dr. Park.
Thank you for having me, and thank you for the introduction, Becky. And thank you everybody for joining us today. Can you go to, actually this slide is good. Joni Blank was a sex educator. She was an activist. She was a philanthropist. And that's a great quote by her. I wanted to just set the setting. But difficulty with sex and sexuality and desire and pleasure. This is a common problem amongst women diagnosed with breast cancer. Over half of women treated with breast and gynecologic cancers report long-term negative consequences of sexual function as a result of their treatment and diagnosis. And this experience is not just unique to, what we commonly think of as, women's cancer survivors like breast cancer and gynecologic cancers. When we do large studies on other cancers, not just pelvic cancers, but presumably other unrelated cancer types, such as lung cancer survivors, they have reported decreased interest in sex by twofolds and 3 times more likely to experience vaginal pain and discomfort after treatment compared to before the diagnosis. So this is a common problem that we really should encourage our providers to address with our patients early and often on a repeated basis. It's all part of our wraparound wellness care. So that's why I wanted to specifically talk about that today. Human sexuality, though, is a complex topic. Even outside of cancer diagnosis, it's a complex topic that affects, many women. The biopsychosocial framework of sexuality implies that every sexual expression consists of an interaction amongst biological, psychosocial, factors, and then also aims to provide a comprehensive treatment to ultimately increase the personal satisfaction and quality of life. Now, Dr. Ruth, who recently passed, used to say, when it comes to sex, the most important 6 inches are the ones between your ears. And that certainly to some degree is true. Certainly the psychological, social, cultural, interpersonal challenges play a huge role in defining our sexuality. But especially for our breast cancer survivors, there is a significant biological challenges that they are also struggling with at the same time. Now that often involves symptoms of menopause due to their treatment, either due to ovarian suppression or hormonal therapy. And they're also dealing with, anatomic challenges after their surgery, changes with their, nipple sensation, especially for those whose, their breasts and nipples are a main part of their erogenous zones. The consequences of menopause and decreased levels of estrogen can lead to painful sexual activity, pelvic floor dysfunction, and penetration. So those are things that we can certainly help address as providers more actively. Next slide. And unfortunately, cancer treatment does change our bodies. For breast cancer patients, we're talking about lumpectomy and mastectomy that does, can potentially change the shape of our breasts, change our sensations. And patients who have a, genetically driven risk factors and BRCA mutation carriers may have to undergo additional risk-reducing surgery ultimately, including removal of the ovaries at a younger age, or possibly also hysterectomy concurrently. And that can put you into abrupt menopause. Consequences of surgery, both from lumpectomy, mastectomy, as well as pelvic surgery, can lead to scarring, muscle atrophy, and potentially issues with nerve damage that can all affect overall strength of our muscle groups, our flexibility, range of motion. So for example, for breast cancer survivors after a mastectomy, it can really affect the range of motion and flexibility and strength of our upper extremities. So are you able to hold certain sexual positions without pain, or is that going to be difficult to do for a long duration of time? Those are all considerations to discuss. And the radiation therapy similarly can cause tissue fibrosis and scarring. Additionally, can cause lymphedema of the upper extremity. Definitely causes a degree of fatigue that affects our libido, our mood, our desire, and our sexual response. Chemotherapy can trigger either temporary or more permanent menopause. And of course, during the treatment, you can have a lot of difficulty with fatigue and gastrointestinal side effects, brain fog during the treatment as a more acute or potentially even longer lasting side effects. You could develop, mouth sores or peripheral neuropathy. I had a patient who told me that they could no longer really masturbate the same way because of the kind of the numbness and pain and tingling in their fingers, or are not able to really kiss or perform oral sex with their partners and engage intimately because of the severity of their mouth sores. Ovarian suppression with especially in premenopausal patients with Lupron can be really abrupt, and the effects can be quite harsh. Hormonal therapy, such as tamoxifen aromatase inhibitors, can also mimic or exacerbate the effects of menopause symptoms. When we talk about menopause symptoms and its effects on sexual function in breast cancer survivors, genital urinary syndrome of menopause is one of the main things that we need to address. Due to the low estrogen level, it causes tissue atrophy if you look at the picture on the right, of the whole perineal area. The perineum is just a kind of anatomic description of this generalized, I don't know if my cursor is visible, I guess not. This whole area, from thigh crease to thigh crease, involving the mons, of course, the labia, the clitoris, the inner labia, the hymen, the vestibule. The vestibule is all this inner area of skin, which is a very, very delicate area of skin between the inner part of the labia. It also involves the urethra and then the and extending to the opening of the vagina. So very areas that tends to become very sensitive after menopause, and also extends down to the perianal tissue as well. So due to the atrophy of these tissues, patients can experience, these effects can also be cumulative. So if you ask patients right up front, they might not really notice the symptoms as much, but 3, 6 months, a year from now, things can be different. So we need to continually monitor and address these side effects with the patients. So it can cause vaginal and vulvar dryness, irritation, and itching, even in the absence of any kind of an infection. It can lead to, of course, painful sexual activity, both because of the sensitivity on the outside and also the proneness for irritation and friction and dryness of the tissue, of the vaginal tissue on the inside, and the atrophy of the kind of the support connective tissues that form a part of the pelvic floor. Bladder and the bladder and the sphincters and the septum tissue between the vagina and the and the bladder. Also responds similarly to the estrogen. So patients with low estrogen level can also develop a lot of bladder irritation, frequent urination, potentially frequent urinary tract infection because that urinary sphincter is a little bit atrophied and a little bit weakened, and is more prone to letting in infection from the outside in. The treatments, of course, we still need to do a full evaluation and not just assume everything is due to the low estrogen level. But once you do a thorough examination, then we, go on to treat these genitourinary symptoms. The first thing I usually review with the patients is just, what are their normal, vulvar care routines? Usually when it comes to the perineum and the vulva vagina, less is more. So, we don't need to use any, really, commercially available pH balance, specialized soap. We certainly don't encourage any kind of direct scrubbing or rubbing of that delicate tissue with either a towel or a bathing sponge, because the tissue can be really delicate. Just clean lukewarm water and very gentle soap that we normally use to clean your body. Just let that wash over and irrigate with lukewarm water. Don't need to be douching or cleaning separately on the inside. There are a lot of non-hormonal moisturizers that I routinely recommend for our patients to keep the tissue nice and healthy. There are different ways of thinking about it. I usually recommend more of a daily moisturizer and more of a restorative solution. The daily moisturizer you can think of as like something that you do as a nightly part of the routine. And for that, I really liked coconut oil. Coconut oil is very safe to use and it's gentle on the skin. Just a very thin layer, just let it melt on your hand. Just a very thin layer on the outside of the labia, and then work your way into the inner labia from up towards the down, and make sure you get to the middle part as well, that vestibule that I talked about, that very sensitive area, and the opening of the vagina, especially that bottom portion of the vagina. That's where things get very sensitive and also causes a lot of pain during penetration. So you want to make sure you get that area nice and with a little bit of gentle massage, a little bit on the inside. That helps kind of stretch that tissue out and massage and moisturize the tissue. And then there are products that are more meant to be kind of rejuvenating. Those are products that you don't necessarily have to use every day. That includes things like Reverie, which is a suppository that's shown there, and contains hyaluronic acid, like what you see actually in some, products for your skincare. One of the few times that actually it's okay to use what you use on the face, on the vulvar area, usually not. But it's a bioadhesive and it's long lasting. It helps moisturize and restore the vaginal tissue. You use it about 2 to 3 times a night. Replens is another product. You don't have to order this online, usually available on regular stores. Doesn't contain hyaluronic acid. I think in terms of the restorative property, Reverie is probably, I see a little bit more benefit than Replens. For those patients where vaginal estrogen therapy is an option, and that includes majority of breast cancer patients in current treatment as well as survivors. Vaginal estrogen in forms of tablets or rings or creams are safe to use in vast majority of breast cancer patients. And I always make this decision in a partnership with their oncologist. But studies in breast cancer patients have not shown any increase in cancer-specific mortality related to consistent vaginal estrogen use. And when we actually check the serum level of estrogen with vaginal estrogen, the elevation is not 0, but it's very, very marginal, not in any clinically meaningful way. So the stance of the American Congress of Obstetrics and Gynecology, as well as the National American Menopause Society, is that vaginal estrogen is safe to use in breast cancer patients. For those who are really wary of using estrogen and want, additional alternative, sometimes I will recommend a progesterone, which is a form of male hormone called dihydroandrostenedione or DHEA. It's this little suppository that's inserted vaginally. It gets absorbed by the vaginal tissue and gets converted in part to a type of male hormone and estrogen and helps restore the vaginal tissue. And even in patients who are on aromatase inhibitors, in whom we actually don't see the conversion to the estrogen, and we don't see any elevation in the serum estrogen level. Surprisingly, studies have shown that it actually does still cause a beneficial tissue effect. So I think we don't completely understand the mechanism of its effects, but it can be an effective solution. Usually the problem with the intrarosa is the coverage issue. It can be formulated in a compounded form. So sometimes I will, do that for the patients. And probably somebody should probably keep me on time, but this slide is actually probably the most important slide. So I will kind of go through the rest of this, and then if we're kind of short on time, I can kind of touch on the main points for the rest of the slides. Using quality lubricants during any type of sexual activity that's with yourself, with a sexual tool or a toy, or with a partner is very, very important. For patients with low estrogen level and sensitive skin, I generally tell them to try to stay away from a commercially available water-based lubricant, although some can be good. Water-based lubricants don't last as long. They dry out the tissue more. They can leave residue that later become irritants and can be a little bit more sticky. So a silicone-based lubricant can be more gentle and hydrating and longer lasting. You can use kind of a hybrid version, both a water and a silicone version. Or coconut oil can also be used during sexual activity as well. There's some concerns about certainly silicone-based lubricants are not unfortunately safe to use with silicone toys because it can degrade the silicone over time. There was some concern with the coconut oil with the silicone toys, but majority of the time it is safe. You just want to wash the toy well, and if you use a high grade silicone toys, usually as a coconut oil is still safe to use with the toys. For some patients who have a lot of pain, especially on outside, especially right at the time of entry, sometimes topical lidocaine, like a lidocaine jelly or a cream that's available on just over the counter, can be effective. You just apply it again in that same kind of that hymenal vestibule area about 30 minutes in advance. And it can, it's not going to numb the whole area, but it can just get you through that initial kind of barrier. So you have less of a blockage, and you can actually, have more pleasure and comfort during sexual activity. Now, the a little bit more, controversial modalities like laser radiofrequency therapy, which promotes collagen growth, are less just less studied. They're, expensive, and the response is somewhat variable. So it's not something that I commonly recommend to the patient. Certainly there are providers in the community who do offer the treatment that the patient is particularly interested in. I will refer them out. Unfortunately, systemic estrogen is not an option for majority of our breast cancer patients, although some patients with very, pre-invasive carcinomas can sometimes be a candidate, and that is a decision that we make in consultation with their oncologist. Now, painful sex is usually due to the continuation of the genitourinary syndrome. And over time, so a lot of anticipatory and preventative, treatment is necessary to keep the tissue moisturized and prevent the tissue from, atrophying and becoming narrower and smaller. I'm talking about the vaginal canal and the vaginal opening specifically. So if a patient has just not had, has been afraid to, or has not been on any kind of therapy that we talked about before, and hasn't been sexually active in a long time, chances are that their vaginal opening is really quite narrow. Their vaginal canal is probably somewhat shortened to very narrow. So it does require some retraining. The vagina is fortunately a fairly, restorative organ that can, kind of stretch and shrink. So with adequate topical therapy that's restorative in conjunction with dilator therapy, we can often restore the vaginal canal to achieve sexual satisfaction and pleasure. We also offer these patients, refer these patients for pelvic floor physical therapy. And I also, encourage these patients to explore different types of positioning to see what angle of sexual activity or vaginal penetration might be more pleasurable or comfortable in this new setting. And if you're interested, American Cancer Society actually has some suggestions of potential, sexual positions that, you might want to try if it's something that you feel like you need a little more guidance on, and you can use a QR code to be referred to that resource. All right, of course, and other than genitourinary syndrome or menopause, there's a whole lot of other more kind of symptoms of menopause that indirectly affect our sexual health and sexual function. So that includes things like hot flashes and night sweats and sleep disturbances. If you are feeling, just hot and sweaty all the time, you're often not really in the mood to be, sexually active. So the treatments can include, behavioral changes, right? Layering your clothes, cooling blankets and pillows can be very effective. Exercise, regular exercise has been shown to, improve your thermal regulation. Hot flashes and night sweats is one of a big factor in what causes a sleep disturbance in menopausal patients, although it's not the only. So, the sleep hygiene is important. There are a lot of non-hormonal effective medications, thankfully, to treat the hot flashes and night sweats, all the way from more, traditional antidepressants like SNRIs, or otherwise known as Effexor, that we use commonly, that can be quite effective in treating vasomotor symptoms, which are the hot flashes and night sweats, all the way to kind of the new kid on the block that's been, newly FDA approved, called Veoza, which act on the hypothalamus. We still run into, because it's a new kid on the block, we run into some coverage issues, but the efficacy is really quite impressive. So those can be potential options. Other herbal remedies. The problem with a lot of herbal remedies in the United States is that just not as regulated. But in the EU, the herbal remedies are better regulated. So some of the herbal remedies that are available in the European countries, like remifemin, that's pictured here, is a blood cohosh product that's produced in Germany and is very commonly used in GYN oncology practices in Germany. And it is available in the U.S. It's something that can be considered for our patients who are interested in potential herbal remedies, and acupuncture can be beneficial as well. Of course, menopause affects your emotional and cognitive changes. Exercise is helpful. Psychotherapy, seeing your counselor is helpful. Sometimes patients need a little bit more medication support. It could be antidepressants. Sometimes patients who, were on kind of ADHD type of stimulants before, who were kind of off of the medication. Sometimes I see the patients needing a little bit of extra additional support after they go through menopause. So it's not uncommon to see patients going back on their ADHD medications after menopause. Changing sexual drive and arousal is a huge topic. And all the other things that I talked about the biopsychosocial model, are really kind of encapsulated in here as well. So I often encourage patients to make sure that they're touching base with their support team and engage with their therapist to kind of reframe their, ideas about sex and pleasure. And just be creative and kind of really explore their new sexuality in a more kind of practical, concrete sense. Using products that help give a little additional stimulation because it's often needed, let's be honest, after menopause, in the genital area for both clitoral and vaginal stimulation. So vibrators can often help increase the blood flow to the genital area and into the clitoris as well. And that vibration effect also helps decrease the pain in the vaginal canal as well as that vaginal opening. Sometimes patients may benefit from additional products, topical products on the outside, and especially the clitoral area. That also helps kind of increase the blood flow and cause a little more, active arousal. So it's, pictured one of the products it's called Quim. It's only available at dispensaries, and you'd want to, apply this at least about, 30 to 60 minutes before the sexual activity. It's not always immediately effective, so you've got to give it a little more time. Certain additional herbal remedies are available as well. It's the more kind of the controversial topic would be the Addy, which is the flibanserin, which is kind of the female Viagra. It's not something that you take as an as-needed basis. It's something that you take nightly, and it takes weeks to potentially see effects. It is FDA approved for generalized hyperactive sexual desire disorder, but it's only been studied in premenopausal patients. So it hasn't been studied in postmenopausal patients. It has certainly not been studied in cancer survivors or breast cancer survivors. And it's not without side effects. So it's not something that I routinely prescribe to our patients. It's something that definitely worthwhile to potentially discuss with your provider. The psychosocial interpersonal support, tremendously important in restoring sexual health. Emily Nagoski, who wrote, Come As You Are. It's a great read if you're, interested in some of the book suggestions. She says, clear the space for really exploring the sexuality that you have instead of the one you're always supposed to have. We are, in fact, capable of confident, joyful sex. So there is, in reality, quite a bit of, grief and loss process in accepting this, kind of this new reality, letting go of a lot of the old preconceptions of what our body was supposed to look like, what the society and ourselves were trained to expect of ourselves and about our sexual response and desire and pleasure. And, and really, embracing, what is the new true you. And our patients often also need some help in navigating some of the relationship dynamics with their partners and relationship issues. They often feel somewhat pressured, or a lot of the times it's self-imposed, but it can be external to be very sexually active with their partners, and to feel kind of guilt and shame if they're not able to. Sometimes their partners are very hesitant to engage in sexual activity because they're afraid that they're going to hurt their partner, or there is a kind of shift in that dynamic and role, because the partners have for a while been playing the role of a caregiver, and how that kind of impacts how we look at each other and desire each other. So these are all things that needs to be discussed, and so I think it's always good to have partner engagement and active communication during our support. So this is a good segue to, I wanted to introduce the Women's Health and Wellness Center. It's, a few years in the making, but it is a wonderful service, that program that was, developed over a number of years, and that has just really launched just down the street. They are a multidisciplinary team, really focusing on a lot of the functional recovery of pelvic health. That includes kind of gynecologic treatments, postpartum, care for our patients. We do a lot of physical therapy after, breast cancer treatment and surgery and radiation. And then down the road, there will be an integrated medicine component where there will be an acupuncturist, and non-pharmacological, and pain medicine specialists. And we send a lot of our patients there for pelvic floor physical therapy, which is hugely beneficial for patients experiencing a lot of, difficulty with arousal and pain and, intimacy. So I just wanted to kind of introduce this as an additional support service that's available at St. John's, that, we can certainly discuss the referral with your providers.
For more information, I just want to close us out. And if those of you want to stay on for a couple of minutes off recording, please do. For past health and wellness recordings, you can look for us on the YouTube channel. Check out our website for other resources. We have a breast health clinic for women with or anyone with a breast problem that needs assistance evaluating it. And then we have our multidisciplinary breast cancer clinic. And you can follow us on YouTube or Facebook or Instagram. So thank you very much again for being with us today, and Dr. Park for such a great presentation.
Thank you.